Okay, so in today's class we are going to speak about posterior circulation stroke. For the sake of understanding what is posterior circulation, just try to remember what I have told you about the vertebral arteries. Vertebral arteries used to come from the subclavian, conjoin together to form the basilar artery. And the basilar artery, I told you that many vessels come out of it. For example, AICA, which is anterior inferior cerebellar artery, and PICA as well, which is posterior inferior cerebellar artery. In addition, they will also give the posterior cerebral artery. So this is cerebellar and this is cerebral, okay? So this is for the cerebellum and this is for the brain himself. Okay, so let's take a look about how to memorize all of this stuff. I mean, they are a lot, guys. So there is basically a little trick that I personally use and I would like to share it with you. I've seen it in Boards and Beyond, and I have to say it was a really good trick. So for the sake of knowing where is the infarction in this human being, in his posterior circulation, is it in his basilar artery, is it in ICA, is it in the posterior cerebral artery, or is it in the BICA, or is it in the anterior spinal artery? How can I know? Well, the trick goes something like this. Brainstem, blood supply. So, yes, this thing. Okay, so there is this really simple picture that can tell you all. Basically, it works something like this. Let's try to take a look at it and try to understand what it means. Okay, so here it is. Oh no. Okay, so it goes something like this. If you remember, we said cranial nerve number 12, 9, 8, and 12, 11, 9, and 8, all of them comes from the medulla. As you can see here, the only one that originates medially is the one that divides by 12. Which one? This one. So you can see that it originates medially while the others originate laterally. Okay? Good. The next thing goes something like this. You can see that the bones, it will be the next four basically. So it will be 8, 7, 6, and 5, and the midbrain will be 4 and 3, and finally 1 and 2 will be directly from the hemispheres. So from these, 6 originate medially, so you can see him here in the midline. 3 and 4 at the midline as well. So this helps us to know which cranial nerve originated from where. But you are like, wait a second, but still I don't understand why this have any relationship with the topic you are explaining. Well, I will tell you. It has the following relationship. So the relationship goes something like this. If we speak about this structure, each of these portion, for example, this is the midbrain, this is the lateral portion, this is the medial portion, this is the bones, lateral or medial, this is the medulla, this is lateral or medial. So when they tell you medial medullary syndrome, it's an infarction of the medial portion of the medulla. Okay, so the patient will have multiple symptoms in addition to which cranial nerve affection? Cranial nerve number 12. Excellent. So cranial nerve number 12, does anybody remember the name of that nerve, by the way? It is the hypoglossal nerve. Yes. Hypoglossal nerve is responsible of the movement of the tongue. So if that's messed up, you know that it's cranial nerve number 12. They will tell you, oh, the patient tongue movement is messed up, his tongue is pointing at one direction and stuff like that. So you know that half of his tongue has paralyzed, and you will be like, okay, so must be cranial nerve number 12. So this must be in the medulla, but since it's a 12, it should be medial medulla, right? Not lateral medulla. So you are like, okay, what supplies medial medulla? That's where this come handy. So you can see, personally, how I remember it. BICA, ICA, BCA. BICA, ICA, BCA. So what's up with that? So BICA is posterior inferior cerebellar artery, ICA is anterior inferior cerebellar artery, and this is posterior cerebral artery. To make it simple, for the midbrain, the whole thing is supplied by the posterior cerebral artery, which is the last portion of the posterior circulation. Remember, please, the posterior circulation goes like this. You have the vertebral arteries which conjoin and make you the basilar artery. So this is vertebral and this is basilar. The basilar, from the lower side of it, we have this coming out, which is the ICA, and then you have this coming out, which is the BICA. And in addition to that, there is one more structure that is coming out. So let me just name everything. So this is ICA, right? And this is BICA. And these two are vertebral, and like this, the two vertebrals are going to make anterior spinal artery, okay? And if it continues like this, they are going to make a thick artery known as posterior cerebral, now cerebral, not cerebellar, cerebral artery. Okay, so that's how it goes. Good, that will be really useful in a second. Let's see. So when we speak about the medulla, if they ask you the blood supply to the area that was infarcted or in which vessel is the infarction in, will be pretty simple actually. Since you know already that like in this tongue is messed up, so it must be 12th cranial nerve, medial medullary syndrome. So that should be medial. Which one is medial here? Let's take a look. And the lower between them, it's the ASA, which is this guy. Okay? Good. Good. So from here, we can understand where is this going. If they give you somebody with a sternocleidomastoideus mastoideus, vagus nerve dysfunction, and have the problem with the swallowing, you need to think about lateral medullary syndrome. What supplies that is BICA. Okay, I messed these up. So here is BICA actually, and here is ICA. Sorry. So the BICA is this one. Okay. So in the bones, the same idea. Cranial nerve number 6, also known as abducens. Abduct the eye. If the abduction is absent, you are like, okay, that's cranial nerve number 6. Which vessel is supplying that area? Which blood vessel is supplying that? Yes, basilar. Absolutely correct. Good. If I give you a patient and this patient is having a facial droop, I mean, half of his face is messed up, like he cannot, if you tell him to blow with his mouth closed, he does something like this. He cannot close his lip. So think, which cranial nerve palsy can lead to that, and which portion of the brain is affected, and which artery will be affected. I repeat the question. The patient have loss of motor movement of his right side of his face. So it's going to be facial, lateral bones. So it's going to be ICA. Excellent answer. Good job. Okay, so one more guy. This guy cannot go down the stairs. He cannot go down the stairs. Why? Because he cannot look down. He always look up. Every time he wanna go down the stairs, he flip it over because he cannot look down. Which cranial? Oh, well, think about it. Which cranial nerve? Which portion of the brain? Which vessel? Okay, I'm seeing some answer. Okay, nice. So the cranial nerve palsy that will not allow you to look down is basically going to be the trochlear, which is the cranial nerve number 4. Can you tell me please, does it originate anteriorly or posteriorly from the midbrain? Posteriorly. and which tumor can compress it? Excellent. Benilioma. Yes. And okay, good. So he cannot look down. So if it was a stroke, as you said, the trochlear, it's coming out from the midbrain, and the whole midbrain is supplied by the BCA. End of the story. So this is how you solve this equation. Now I'm going to read the symptoms. The symptoms are pretty much tricky, and they are difficult. And to memorize for every single artery, it's just hell. Just know the cranial nerves, and according to which cranial nerve is messed up, you will write your answer. Just want to add a few more things. In general, I'm not saying that this is always, but in general, in the brainstem, okay, just a momento. Let's say that this is the brain stem. If this portion is the medial portion of the brainstem, this is the lateral portion of the brainstem. In general, not always true, I repeat, the motor function is going to be medial. Motor function is going to be medial, while the sensory function is going to be lateral. The sensory function is going to be lateral. The sympathetic function is going to be lateral. The sympathetic function is going to be lateral. This is in general. This is not always helpful, so always use the cranial nerves. But in general, the situation is like this. You can use it to proof check, not to check. So let's see what they write here. BCA. Oh, BCA. Which portion of the brain is supplied by the BCA? The posterior cerebral artery. Which portion of the brain stem is supplied by it? Okay. Which portion of the brain stem is supplied by it? Brain stem. Just showed you this picture. The midbrain, guys. Okay, so the occipital lobe as well, that's correct, but mainly it's going to be the midbrain. You can see in the infarction of it here. Anyway, so the patient is going to have contralateral hemianopia, which is inability to see, with macular sparing. What does that mean? Well, basically, the patient, if you take a look at his visual field, this is the visual field. It's subdivided into 4 portions. So this patient will have contralateral hemianopsia. Let's say that the infarction, this is the occipital lobe. Of course, you have 2 of them, not 1. So let's say this one was messed up. So contralateral side, this side is going to be messed up, okay? So when you look at this side of this patient, remember it dissociated a couple of times, so this area will be the one messed up. But it will not be full. Basically, this area will be spared, always. Well, except in some situations. So why it is spared? It's spared because of the connection between the MCA and the BCA. So that connection will still allow the macula, which is this portion, to gain a blood supply, so the patient will not have a blindness. So for him, the word will look like this. Total darkness like this. Okay? By the way, it's 2 eyes, not 1. Keep that in mind. Okay, good. So if they ask you why it is sparing the macula, the answer is because that there is a connection between the MCA and the BCA. Okay, good. So let's take a look at the next thing. Alexia without agraphia. What does that mean? You know, guys, sometimes you bring a person and you put him out on the stage and you tell him to read something. They call him dyslexic. He reads, like if you tell him to read something in his brain, that's not problematic. He will just read it. But if you tell him to read something like a text, he will be like, he will be really frustrated. That's dyslexia. Alexia is inability to read even. Agraphia is inability to write down something. Maybe you have maybe you notice some people sometimes have really serious problem with writing down stuff, like me. I can read English perfectly, but I have a serious problem in some pronunciation and some word. That's okay, but the problem with writing, like I know what I want to write, but when it comes to writing, I keep forgetting the letters. I'm not forgetting. I have dysgraphia. That's the trick. So dominant hemisphere is the one affected. Which one is the dominant hemisphere? Left one. Yes. This is true in whom, however. This is true in people who are right-handed. It's the left one. Personally, I used to be left-handed, but I converted to become right-handed. So I guess my right side is the dominant one, not the left one. Anyway, so in left-handed people, it's the right side that is dominant, okay? It's vice versa. Okay, so extend to sublinium of the corpus callosum. What is sublinium of corpus callosum? Basically, the corpus callosum itself, which is the connection between the right and the left hemisphere, has multiple portion in it, okay? And the posterior portion of the corpus callosum, of course, this is the corpus callosum. And inside of the corpus callosum, it contains area. So you can see the sublinium, which is this, the posterior most portion, the trunk, and the ginua. Ginua means basically a knee. You see how it looks like a knee. So yeah, the sublinium will be most likely affected. Why? Because we are speaking about the posterior cerebral artery. Posterior cerebral artery. Okay, so they also can have prosopagnosia in the non-dominant effect. So let's start first of all to speak a little bit about the prosopagnosia. Oh, yes. So what's up with that? These people have this problem, like, you know, you are, let's imagine that my classmate had this problem. He sees my face, he hear my voice, he know my voice, he does not recognize my face. I'm in front of him. He's not blind, guys. He sees me, but he does not he cannot know who I am for him. Okay? But when he hear my voice, he's like, wow, you sounds exactly like my classmate. I am your classmate. No, it's not your face. Well, okay, what about your face? This is where it gets messed up. You bring a mirror for him, put it in front of him, and tell him, who's that? He takes the mirror and look at himself, and they are like, you put me in someone else's body? Yeah, he cannot recognize his own face. Cannot recognize the face of his mother, father, siblings, anybody like that. Love does not matter. He cannot recognize the face of his wife. Well, maybe he can, but he just saying that he cannot. Anyway, so basically in this case, the patient will be unable to recognize the people's faces in general. Okay, so that's posterior cerebral artery. If you think about the cranial nerve affection, which cranial nerve do you think will be affected in case of posterior cerebral artery infarction? Which cranial nerve? 3 and 4. Nice. Basilar artery. Cool. Basilar supplies, well, it goes through the bones, medulla, and the lower midbrain. This is useless. Why? Because you need an exact area. So which exact area of the brain is solely supplied by the basilar artery? Remember the picture. Always go back to the picture. I highly advise you guys to draw it down many times until you master it, because it's just simple. Like it contains 5 structure and that's it. You can use the rule of 12 to gain all of the cranial nerve and you can answer anything. So the basilar basically supplies the medial portion of your bones. Okay, good. So contralateral, corticospinal or corticobulbar tract. Basically the corticospinal is the motor for the trunk / the limbs, while the corticobulbar is the motor function for the face, like the facial nerve, right? So the corticobulbar will bring the info from the prefrontal gyrus into the bones, and in the bones it meets with the cranial nerve number 7, which send the motor info to the face, right? But the movement from the cortex to the bones and nucleus, well, to the facial nerve and nucleus in the bones, is mediated by the corticobulbar tract. Okay? When you hear the word the patient has bulbar symptoms, start thinking that he has a problem in the in the brain stem. Bulbar comes from the word bulbous. Bulbous means onion. What looks like an onion? Brain stem looks like an onion. Okay? Onion. Brain stem looks an onion. So let's take a look at the brain stem. I really don't know why they call him an onion. But for me, it does not look like an onion, but they say it looks like an onion. I don't know. It's your judgment to say if it looks like an onion or not. This thing. Okay. So, guys, what is more dangerous? To get shot in the head or to get shot in the brainstem? I mean, to get shot in the hemisphere or to get shot in the medulla? Yep, you will for sure get the patient knocked out. Okay, so ocular cranial nerve nuclei and paramedian pontine reticular formation is also there. So remember, this thing is the thing responsible for us getting a coma if it's destroyed, or to go to sleep if it is shut down. So if the RAS is spared, which is basically the reticular formation, consciousness is preserved. But if it is destructed, you will go to sleep. Quadriplasia, which is loss of voluntary facial, mouth and tongue movement. Basically, you will be paralyzed, all of your body, not one portion, and tongue movement. Okay? Remember what I told you? Most medial brainstem problems lead to motor problem. Okay? Not completely true every single time, but in general. So the patient here have basilar artery, which supplies, as you said, the medial portion of the bones. Thus, he has the motor symptoms. Loss of horizontal but not vertical eye movement. Why? Because it supplies the bones. What comes out from the bones? Which cranial nerve that has horizontal movement of the eye originate from the bones? Well, basically, just tell me which cranial nerve originated from the bones. Okay, yes. So from the bones, we have a cranial nerve number 8, 7, 6, and 5. The only one from these that I have just mentioned that can move the eye is a cranial nerve number 6. I hope you remember that the function of a cranial nerve number 6 was abduction, which is the movement the eye to the outside. Well, in a horizontal plane, right? However, the vertical movement is mediated by cranial nerve number 3 and 4, which are not affected by the basilar artery infarction. They are affected in case of the BCA, right? So that's why I told you that if you master the cranial nerve, all of these can be solved. So loss of horizontal, not vertical eye movement, lock-on syndrome, basically the patient, if the RAS was spared, he know what is happening around him, but he literally cannot move any little muscle in his body. He's totally paralyzed. Everything. So he cannot even open his mouth. He's just sitting there. Is he conscious? Yes. Can he hear you? Absolutely yes. Can he see you? Yes. Can he make any movement? No. So that's scary. Nightmare, I know. So, to make it worse, does he feel pain? Yes. Does he feel uncomfortable? You know when you are laying on bed and you don't move for a while, what happens with you? You become uncomfortable, okay? Does he feel uncomfortable? Absolutely. Can he do anything about it? No. Does he have his back itching? Yes. Can he do anything about it? No. ICA. So the ICA, if you take a look at this picture, it's here, supplying the lateral bones. So you will tell me which cranial nerve are affected. Lateral bones, come on. Okay, you missed one. Which one you missed? Okay, good. 8, 7, and 5. So they write facial nucleus is affected, which is 7. Vestibular nucleus is affected, which is 8. Spinothalamic tract as well. And the spinal trigeminal nucleus. These two are sensory, right, guys? These two are sensory. So that reminds you of what I have told you. Lateral lesion are sensory and sympathetic. Remember? Lateral injury are sensory and sympathetic, while medial lesion are motor. Sympathetic fibers, middle and inferior cerebral peduncle as well, which is the legs of the cerebellum, and labyrinthine artery. Labyrinthine artery is an artery that goes to your middle ear to allow you to hear. So, and your inner ear. Paralysis of the face will occur. Lower motor neuron symptoms versus upper motor neuron lesion and cortical stalk. What does that even mean? Well, guys, remember, if this is my face, and this is my eyes, this is my mouth, this is my nose. If I get a lower motor neuron symptoms, and you will understand why exactly I speak about this, sadly later in the book, which is here. Oh, actually, let me just explain it here. That will save me time. So, yes, this is the facial nucleus, which is located in the bones, as you know. But the information to get from the cortex to the facial nucleus, it has to go through the corticobulbar tract, or also known as corticonuclearis tractus, corticonuclearis in Latin, okay? So it goes between between the cortex and nuclearis, which is the nuclei of the brainstem, or corticobulbaris, which is between the cortex and the bulbus, which is the brainstem. So the idea is like this. When the info goes through this guy, it reaches here. And after it reaches the facial nucleus, the facial nucleus itself has two parts, an upper and lower division. This is true by both sides. I mean that both of your cortices will give sublimation to that area, which means if I have an infarction here, this portion, the lower one, will get messed up. But what about the upper portion? Nothing. Why? Because the other side is going to compensate for it, okay? So in case of the motor cortex himself getting infarcted, you will only have symptoms of the lower division. The upper division will be spared because of contralateral compensation for it. The lower division, destruction, dysfunction because of motor cortex's lesion, is going to make you have symptoms in the lower side of your face, somewhere, something like here. So that means the patient will be unable to strongly close his mouth. But if you take a look at the lesion, if it's occurring at the lower motor neuron, I mean, let me destroy the facial nuclei himself, or destroy the cranial nerve number 7 himself. That will lead to symptoms both in the upper and the lower face. So the patient cannot totally shut his mouth, and also he cannot totally move his eyelid, okay? He cannot close his eyelid. If he cannot close his eyelid, his eye will become super dry, and eventually he will lose it. So let's see what they write here. Yes, less lacrimation, less salivation, less taste in the 2/3 of the tongue, basically facial nerve palsy, vomiting, vertigo, and nystagmus, bulbar symptoms, decreased pain and temperature sensation because of the affection of the so the vomiting, nausea, and vertigo, this because of the vestibular nuclei, which is responsible for your balance and sensation of your location. Decreased pain and temperature sensation from contralateral body and ipsilateral face. This is due to the affection of the spinothalamic tract and the spinal trigeminal ganglia. So, as I said before, it's not only the rule of sensory being lateral and motor being medial. It's not always true, but in general, it works. So, ipsilateral Horner syndrome. What is Horner syndrome? It's due to the affection of the sympathetic fibers. The patient is going to have the following: miosis, which is a constriction of the pupil of the eye, ptosis, which is an eye drop, and anhidrosis, which is inability to the half of the face to basically make how do you say that? Sweat. It will not sweat. Ipsilateral ataxia can occur because of affection of the cerebellar peduncle and dysmetria, which is the patient cannot measure the distances correctly. For example, you will get into his room and he'll be like, "Doctor, be careful, you almost hit my face." And you are 3 meters away from him, okay? So, ipsilateral sensorineural deafness and vertigo. Okay, why? Because of the labyrinthis artery that will lead to the sensorineural deafness because it supplies the inner ear. Lateral pontine syndrome, facial nuclei are specific for ICA lesion. However, the trigeminal ganglia is not specific for this, okay? So, facial nuclei is specific for lateral pontine syndrome. If you memorize this, this is a piece of cake for you. Okay. The next thing here we have is the posterior bica. Bica, well, is supplying the nucleus ambiguous, vestibular nerve, lateral spinothalamic tract, and spinotrigeminal tract, sympathetic fibers, and inferior cerebral peduncle. Again, the trick is with knowing which cranial nerve is supplied. Bica, let's go to the picture. Bica is here, so that is the lateral, so it should be 9, 10, and 11. Okay, so nucleus ambiguous, 9, 10, and 11. This arthria, dysphagia, inability to swallow, because the cranial nerve number 9 and 10. Hoarseness, same thing, decreased gag reflux, number 10, and hiccups, number 10. Because of the affection of the vertebral nucleus, the patient is going as follow. The vomiting, vertigo, and nystagmus can occur in this patient because of this vestibular nuclei affection, which is responsible for your balance. These are responsible for sensation. So the patient will have low pain and temperature sensation from the contralateral side. Horner syndrome, again, because sympathetic fiber and the cerebral peduncle will also lead to cerebellar symptoms, which are the ataxia and dysmetria. This is also known as lateral medullary syndrome, also known as Wellenberg syndrome. So nucleus ambiguous effects are specific to the biga, so cranial nerve number 10, 11, and 9. And yeah, basically keep in mind the hoarseness and the dysphagia that will give away the cranial nerve number 10 and 9, and that can help you to choose the bica on the test. The anterior cerebral artery, in that case, it supplies what it supplies. Can somebody remind me what the anterior cerebral artery, anterior spinal artery supplies? What does it supply? Well, it supplies the medial portion of the medulla, right? So these patients are going to have the following. Contralateral, corticospinal tract affection because it's lateral, basically, medial lemniscus, and caudal medulla. So let's start from up. Corticospinal tract. It's basically the motor stuff, right? Medial motor. Contralateral paralysis of upper and lower lip. Medial lemniscus system, if you remember, that was the system that was utilized after the dissociation of the posterior columns fiber. So this patient will have a low proprioception in this patient. The next thing goes about the caudal medulla, which supplies the hypoglossal nerve. And the hypoglossal nerve affection will lead to a problem in movement of the tongue. So decrease in contralateral proprioception, ipsilateral hypoglossal function, which will make the tongue to deviate towards the lesion, okay? The tongue is going to deviate towards the lesion. This is important. It's going toward the lesion. So if the lesion was right, it's going to the right. If it was left, it's going to the left. Okay, medial medullary syndrome caused by an infarct of the paramedian branches of the anterior spinal artery and the vertebral arteries. So please know about medial medullary syndrome and the affection of cranial nerve number 12, while lateral medullary syndrome, it was 11, 10, and 9. So let's take a break for 10 minutes, and I will see you guys in 10 minutes. Continue. So the next thing to speak about is going to be the central post-stroke pain syndrome. First of all, I want you to know what is this all about. If you have destruction of one portion of your thalamus, you get something called thalamic syndrome. Well, how did we discover about this initially? Back in the time, the Nazis used to do something called, like, they are actually the masters of neurology. They discovered it by trying. So basically, they brought one human being, they removed his thalamus, and after removing the thalamus, they realized that this patient developed neuropathic pain. Neuropathic pain is feeling like a really, really hot liquid was poured into your body. Simultaneously, there was knife stabbing you. That's neuropathic pain. Due to thalamic lesion, of course, we don't remove it to the patient. Thus, for the days, it's only happening because of strokes. Initial paresthesia, which is absence of the sensation, followed in weeks or months by allodynia. Allodynia, which is really, really slight pain, guys. Really, really slight pain. Like hitting your hand to the table will make you having this humongous pain that is both hot and stabbing in nature. Anesthesia, which is altered sensation on contralateral side. It occurs in 10% of the stroke patient. Okay. The next one is a diffuse axonal injury, which is happening in people having this acceleration, deceleration injury. For example, you are in the car going fast, and suddenly you crash into something. So what happens exactly? If you imagine that this is your skull and your brain is inside of it, it will go forward super quick and then it will go backward again. If you remember, your brain has to the outer portion, the cortex, and then inside of it, you have the internal capsule and the other structure. However, the cortex is full with the bodies of the neuron, right? And from it, the axons are going. So basically, what will happen that a shearing stress will occur, which is going to destroy all of these axons and separate them from the, separate the cortex from the internal capsule. This will lead to a super serious injury, by the way, which can lead to the patient to get a coma and even vegetative state. So traumatic shearing of the white matter tract during a rapid acceleration, deceleration of the brain. So as I said, this is the bodies of the neurons in the cortex. This is, and they look like this. When the acceleration happens, everything is moving together, and then the deceleration happens, the bodies keep moving, but the axons are still sitting. That will lead to something like this, right? So that led to basically destruction of all of that axons. Usually result in a devastating neurological injury, often causing a coma or persistent vegetative state. MRI show multiple lesion, also known as punctuate hemorrhage, as you can see here, 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 and here, and here. Sorry, and here. Okay, so all of the black stuff. Good. Involving the white matter tracts. So the next thing is called aphasia. Aphasia, it's basically the patients will have a serious problem in speech. We have a Broca aphasia, Wernicke aphasia, conduction aphasia, and global aphasia. Let's start speaking about them as follows. Aphasia, a higher order language defect, inability to understand, produce, or use language appropriately. So you can still speak, but it does not mean that you can speak. What do I mean by that? If I'm speaking nonsense, for example, the two cats flipped the powder over the charger and they had two absolute ridiculous words that make no sense. So that's a type of aphasia. By the way, anybody remember which type of aphasia it is? I was totally fluent. I was able to say everything, but I made zero sense. Which type of aphasia it is? Let me repeat the aphasia. Excellent. Somebody said Wernicke aphasia. Yes. So, the next thing, it's going to be as follows. They say, caused by a pathology in the dominant cerebral hemisphere, which is usually in the left, in people who are right-handed. This arthria is a motor inability to produce speech. It's a movement deficit. For example, a deficit in cranial nerve number 10 or cranial nerve number 9. So mechanically, they are unable to speak. Or somebody with a like problem in his lips, for example, or his tongue himself. He cannot speak because of actual mechanical problem, not because of a high order language deficit. Broca aphasia, also known as an expressive aphasia, this patient basically will have a destruction of the frontal lobe area of language. Broca area is an inferior frontal gyrus of the frontal lobe, and it's associated with a defect of the language production. Remember, these patients are frustrated, but their insight is intact, which means when you tell them, how is it going with you today? So he will be like, huh? So that's a frustration. That's Broca aphasia. So they are unable to get the word out, okay? So it goes something like this. Patient appear frustrated, but their insight is intact, which means they still can understand you fully, but they cannot speak. Broken boca. Boca is mouth in Spanish. Okay, did not know that. Wernicke, receptive aphasia. First of all, the symptoms, then we go to where it is. Wernicke is a word salad that makes no sense. However, the patient is a fluid. For example, when I say phone, speaking, wireless, and there is headphones, and looking bed, and there is 2 tables and 1 idiot. So that makes no sense. It's basically Wernicke aphasia, word salad. So, Wernicke area is a superior temporal gyrus in the temporal lobe. Is associated with an impaired language comprehension. If you ask the patient, what's up today? He will answer something totally different. First of all, he will not understand you, but to make the matter worse, he will make no sense. So he does not understand you, and yeah, it's messed up. One more thing about the insight here. So here, insight intact, which means the patient with the Broca aphasia, he realizes he has a problem. But the patient with Wernicke aphasia, he have no idea that he has a problem. So he will not come to you. Somebody will bring him to you, okay? The next thing is a conduction defect, which is the connection between the Wernicke and the Broca area, and it's controlled by something known as the arcuate fasciculus. People with arcuate fasciculus dysfunction, they can speak. They can listen to you. They understand you, but they cannot repeat your words exactly. For example, if you tell them, sir, can you tell me how was your day? He will be like, everything is fine with me today, doctor. If you tell him, can you understand me? He will tell you, yes, doctor, I do understand you. But if you tell him, can you repeat the following sentence for me, please? 2 boys going up the stairs, and he will be like, 2 children going to the 2nd floor. So he do understand you, but he is unable to repeat the exact same sentences. That's conduction defect due to arcuate fasciculus dysfunction. A global aphasia, this patient will be mute. It's when you destroy both the Wernicke and the Broca area, the patient becomes mute. Aneurysms, abnormal dilatation of an arteries due to a weakening of the blood vessel. We have a saccular aneurysms, and we have the Charcot-Bouchard microaneurysms. Make a quick note, saccular aneurysms are big, Charcot-Bouchard aneurysm are super small. So saccular aneurysm, also known as perianeurysm, occurs mostly at the bifurcation of the vessels, at the cycle of Willis. So the most common site is in the junction of the anterior communicating artery and the anterior cerebral artery. It's associated with autosomal dominant polycystic kidney disease. Remember, autosomal dominant polycystic kidney disease occurs mostly in after sometimes, right? Like in old people, exactly. While autosomal recessive, more younger. Autosomal dominant has many cysts. It has a cyst in the liver, cyst in the kidney, they have mitral valve prolapse, and they have cyst in the brain, which is the aneurysm. In addition to that, people with autosomal recessive polycystic kidney disease, they don't have the aneurysm. Instead, they have hepatic fibrosis. Ehlers-Danlos syndrome, a connective tissue disorder, and other risk factors include advanced age, hypertension, and tobacco smoking. Okay, usually clinically silent until it ruptures, which is the most common complication. Basically, any aneurysm has a risk of rupture. Subarachnoid hemorrhage, when it occurs after the bursting of the aneurysm, the patient will be complaining of the worst headache of my life, or a thunderclap headache. It's like a electrical shock to his brain that happens suddenly. And he will have focal neurological deficit according to the place of the hemorrhage. It can also cause symptoms via direct compression surrounding the structure by a growing aneurysm. So, if it was at the anterior communicating artery, please remember what I'm speaking about here. I'm speaking about the cycle of Willis. So, let's take a look at the cycle of Willis. Yes, so when I speak about the anterior communicating artery, it's somewhere right here. Okay, it's going anterior to, what is this? This is the chiasma optica, the optic chiasm. Okay, okay, so compression will lead of the optic chiasm will lead to a bitemporal hemianopsia, which is, this is the visual field, this is will be messed up, and the other eyes, this is will be messed up. This is hemitemporal hemianopsia, bitemporal hemianopsia. Contralateral lower extremity hemiparesis can occur, and sensory deficit, all of this because of the compression effect. The next thing is the MCA rupture. It can lead to an ischemia in the MCA distribution to the vessels supplied by the MCA, which is a huge portion of the brain actually. I mean, if you speak about the brain, all of the lateral portion of your brain is supplied by the MCA. Contralateral upper extremity, lower face hemiparesis, and sensory deficit. However, we do not see any affection of the lower extremity. Why? Because affection of the lower extremity happened at the anterior communicating artery, because the lower extremity is supplied by the ACA, while the upper extremity and the face, it was MCA. So in case of MCA aneurysm rupture, you will have an MCA symptoms, which is upper extremities plus face. But if we speak about the anterior communicating aneurysm rupture, it will be basically the anterior cerebral artery, which is leading to the exact same problem. Posterior communicating artery compression will lead to an ipsilateral cranial nerve 3 palsy, which is going to lead basically to mydriasis, which is a blown up pupil, which is big pupil looking at you. Okay, why? Because the parasympathetic action, which is the ptosis, is not going through. So yeah, may also seen with ptosis down and out eye type of thing. Charcot-Bouchard aneurysm goes something like this. It's quite common, mostly because of hypertension. So yeah, common associated with hypertension. Basically, it's hundreds of really small aneurysms affect the small vessels, which is lenticular striate. Does anybody remember the lenticular striate is a branch of what? Which artery is lenticular striate a branch of? So that's correct, the MCA. It's a branch of the MCA. Okay, in the basal ganglia and the thalamus, and thus the patient will have a pure motor symptoms. So it causes hemorrhagic intraparenchymal stroke, not visible on an angiography. However, it's super small, so it leads to something known as lacunar infarction. And in that case, it's going to have a pure motor type of stroke. Fever versus heat stroke. The fever has always, it should be less than, well, not always, actually, usually less than 40. It can go up than 40, but usually. And the heat stroke is always more than 40. So the fever causes, remember, cytokine activation during inflammation. If you remember the prostaglandins E and the interleukin 1. Yes, so it's cytokine mediated. And the complement is febrile seizure, which is a type of seizure that is benign, usually self-limiting, really common in some infectious disease such as measles or rhesiola. Management, acetaminophen or ibuprofen, because they reduce the amount of prostaglandin Z and thus reduces your temperature. However, keep in mind that they do not prevent the febrile seizure. Antibiotic if it was due to a bacteria, basically. Heat stroke, inability of the blood of the body to dissipate the heat, which is exert out the heat. It's usually when the temperature is more than 40. CNS dysfunction will occur. Well, basically the patient will become confused, and organ damage will occur. Acute respiratory distress syndrome will occur in this patient with rhabdomyolysis. So in addition to that, we have the following The heat stroke can occur when the patient has the acute respiratory. Why they develop ARDS because of the heat stroke? Well, the reason is that in heat stroke, the patient can have destruction of his endothelial cells of the blood vessels, which will allow the fluids and the proteins to pass from the blood vessels into the alveoli, promoting to ARDS. You need to do rapid external cooling. Don't give acetaminophen, useless. Rehydration and electrolyte correction, because that's what can kill the patient. Arrhythmias. The next topic is about seizures. Seizures are characterized by a synchronized high-frequency neuronal firing and with variety of forms. Personally, I think about seizures as basically having a storm of electricity inside of your brain. So the electricity is always made in a precise fashion, except in seizure that the shots of firing will be all over the place. So, okay, seizures, it sucks for the patient. They feel this motor disability and all of this stuff. But my question is, if the patient keep getting seizures, will that lead to any actual anatomical problem? Well, in reality, yes. So, basically, if you keep getting seizure, that will lead to anatomical problem changes in the brain. Your brain will start to shrink down in size, okay? This is also known as a disease called Rasmussen. Rasmussen encephalitis is a type of a recurrent seizure disorder that occurs in children between 2 to 5 years old. It's not mentioned in the book, but I have seen a question about it. That's why I'm speaking about it. So in this Rasmussen encephalitis, the patient between 2 to 5, they will keep having this recurrent seizures that does not stop. We don't understand why they happen in the first place. We know that it is inflammatory in action, probably autoimmune. But the interesting things, cortisol don't work on it, and we don't know why. The only treatment that is now available in the market is, because it happens in babies, well, not babies, little children between 2 to 5 years old, and it affects only one hemisphere. What do? We remove that hemisphere. So that's pretty severe type of a treatment. However, if you remove a 2-year-old half of his brain, can he move his hand and leg later in life? Yes. So in Rasmussen, we do remove half of the brain. The earlier the better, the later the worse. And he will get better. However, there is a good story about like new forms of treatment provided, which is putting little electrode on the head and the brain himself, an implantation that leads to firing of these electrodes and reducing the severity of the seizures. Thus, however, the removal of half of the brain is still the management of choice. We have parietal focal seizures, affects single areas of the brain, most commonly originate at the medial temporal lobe, as you can see in the picture here. So yeah, it's focal. Guys, to make it simple for you, focal versus generalized seizure. In the first one, in the partial one, the focus of electricity is singulate. It's from one area, while in the generalized, it's from all over the place. So they have subdivided it into two types, simple and complex. Simple, consciousness is intact. Complex, you lose your consciousness. So simple partial seizure can be motor, sensory, autonomic, or even psychic. You can imagine stuff happening. Hallucination can be due to a seizure. Complex partial, the patient will have a preceding automatisms, which is an improper mouth movement like biting, suckling on your lips, and seizure, okay? So epilepsy is a disorder of a recurrent unprovoked seizure. Febrile seizure is not an epilepsy, so it's just like one. If you have multiple seizures occurring at different periods of time, we call that epilepsy. Status epilepticus is a continuous, more than 5 minutes or recurring seizure that may result in a brain injury. Okay, so if you have a seizure that lasts more than 5 minutes, we call it status epilepticus. Okay, well, it's lasting. If a seizure lasts for a really short period of time, it's a problem. But if it's lasts for a really long time, it can kill you. Why it can kill you? Because, guys, when you are in a seizure, can you breathe normally? No, you cannot. So if it lasts more than 5 minutes, you need to halt it. You need to stop it right now. The way to halt it is to bring the patient, give him lorazepam, and it will stop. You must give benzodiazepines to halt it if it lasts more than 5 minutes. If the lorazepam does not work in the future, we'll speak about the fact that we give phenytoin, and after phenytoin, we give lorazepam again, and then phenytoin again, and then if that does not work, you have to do total anesthesia on the patient, okay? Because seizures can kill the patient. Causes of seizure by age, it's in children, can be genetic or infection, febrile seizure, it's not an epilepsy, could be congenital or metabolic. The adults, we have tumors can cause that, trauma, stroke, and infection. If I was you, I will memorize the first one from each one. In elderly, it's a stroke, tumor, trauma, metabolic, and infection. So in children, most commonly genetic, in adult, most commonly tumor, and in elderly, most commonly stroke. You can see here that we have the following types of diffuse seizure. The first one is absence seizure. Pretty common, also known as petit mal seizure. Happens mostly in children, in a class. You know that child with you in a class, he's in the class and suddenly he start doing this automatism, which is like, and he start looking at blank stare, looking at the space and not focus. You speak with him and he's like, and suddenly he gets back into it. He get back to consciousness, okay? So that's a petit mal seizure. On the EEG, you will see a 3 hertz spikes and waves discharge. You don't have to memorize that. You just have to know that it exists. You don't have to visualize that. I mean, you don't have to know the EEG and how it looks like. Just know about the 3 hertz thing. Short, usually less than 10 seconds, the seizure itself, but frequent, they keep reoccurring. Leads to blank stare, and there is no post-ictal state, which means mostly in seizures that are generalized, the patient have a post-ictal state, which means after the seizure ends, he's confused. It does not have been an absence seizure. It can be triggered with hyperventilation. Myoclonic seizure is a quick repetitive jerks that happens, most commonly occurs before sleeping. Tonic-clonic seizure, it's also known as a grand mal seizure, alternating stiffness of movement, and the patient will have a post-ictal confusion. He can urinate himself and he can bite his tongue and actually cut it. Keep in mind that it has 2 phases, the tonic phase and the clonic phase. I mean, the patient is standing, suddenly he drops, that was the tonic phase, and then he starts shaking, that is the clonic phase. Again, patient is standing, when he drops, that's the tonic phase, he starts shaking, this is the clonic phase. Tonic is the stiffening, and a tonic, it's a drop that happens. Drop seizure. So the patient is normal, suddenly he faint and boom, to the ground, falls to the floor. Commonly mistaken by fainting. Okay, so let's take a look here. The seizures, the focal seizure. If it impairs your consciousness, it's complex. If it does not, it's simple. It can convert to a generalized one, a tonic-clonic one, by the way. So the tonic-clonic one, remember, we have a tonic phase and a clonic phase. The patient will have an alternating stiffening and movement. The tonic phase, the patient will have the stiffening, and in the myoclonic phase, it's a quick repetitive jerk that occurs mostly before sleep. A tonic drop seizure, so simply the patient drops to the floor. Absence seizure, petit mal seizure, blank stare with no post-ictal confusion, mostly in children. Okay, so and highly associated with calcium channel problem, has a 3 hertz spikes and waves on the EEG. The next thing is going to be about headaches. We have a cluster, migraine, and tension. This is the most common. This is the second most common. This is the least common. By severity, this is the least severe, more severe, most severe. Okay, headaches. Pain due to an irritation of a structure, such as the dura mater, which is, you know, the meninges, cranial nerve, or extracranial structure. Primary headache include cluster, migraine, and tension, but that's not all of them. So, migraine and tension headache are more common in ladies, while the cluster in men. That's why conveniently in the picture here you can see 2 ladies and 1 man. And they write here, secondary headaches include subarachnoid hemorrhage, meningitis, hydrocephalus, neoplasia, or giant cell temporal arteritis. So these are other diseases that can lead to headache as a consequence. Subarachnoid hemorrhage will lead to a headache, but the headache will be the worst headache of my life type of thing, and the patient will have nausea and vomiting. In meningitis, the patient will have photophobia, which is he's really scared from the sun, and he will have the temperature. Hydrocephalus will lead to focal neurological symptoms, in addition to papilledema, the same with neoplasia. Giant cell temporal arteritis will have a physical appearance of the temporal artery with pain in it on compression and on palpation. So the cluster headache is a unilateral, it will be on one side, 15 to 3 hours and repetitive. It sucks. This one is one of the worst type of headaches you can have. It's an excruciating periorbital pain, suicide headache. Why suicide headache? Because it's so bad and it keeps reoccurring that the patient decides to take on their life because it does not stop. With an autonomic symptoms. This is super important because it's the only one between all of them that has actually autonomic symptoms. So the man will be crying, and rhinorrhea, which is his nose start passing discharge, and conjunctival injection in which his eye will be red. May present with Horner syndrome, which is the patient will have miosis, ptosis, and anhidrosis, small pupil, his eye drop, and he cannot sweat from his face. More common in males. Acutely, the treatment of a cluster headache is sumatriptan. Well, basically, they halt the headache. They cannot be used to prevention, just in an acute state. Under 100% oxygen, they love to ask about that. The prophylaxis, however, is with veramapil, a calcium channel blocker. The migraine, it's unilateral, one side of the face, 4 to 72 hours. It's a pulsating type of pain with nausea and photophobia, and or phonophobia. It might have aura. What is aura? Basically, before the migraine starts, the lady will start to feel that, oh, I have focal neurological symptom that always precede my seizure. For example, for some people, it will be a specific smell, a smell of rubber, for example. Other people might say that I have flashes of light. Other people will say, oh no, I feel twitching of my leg. That's aura, focal neurological symptoms that precede a migraine attack. Due to the irritation of cranial nerve number 5 and the meninges or the blood vessels with a release of something known as vasoactive neuropeptide, like substance P or calcitonin gene-related peptide, these will lead to a local inflammatory reaction inside of the brain. Acutely, you have to give NSAIDs, triptans, dihydro, and the ergos, the ergotamines, and antiemetics, because the migraine make the patient really nauseous, like, D2 receptor blocker. So for a prophylaxis of this, you do lifestyle modification, sleep good, exercise, and diet, because if people who have insomnia or problem sleeping are the highest risk, beta blocker can prevent it. Amitriptyline, an anti-epileptic with topiramate, valproate can protect you from that. If none of that work, you can try botulinum toxin injections. And the last set of therapy, which actually quite work well, but we don't use it much because it's really expensive. It is the anti-CGRP monoclonal antibody, which basically makes an antibody against the calcitonin gene-related peptide, which is the cause of the migraine, because it leads to local inflammatory reaction. Okay? So it's a pulsating, 1 day duration, and unilateral nausea and disabling. If you have a patient who has that, the first advice to tell him to do now is to take his NSAIDs or triptan and to sit in a calm, dark room without speaking with anybody, because when they go and stay in a loud room, it makes the pain worse. Tension headache, all of us have it, really, really common. It's a bilateral, it's a band-like headache. It's like having a crown on your head More than 30 minutes, typically 4 to 6 hours, and it's constant. It's a steady band-like headache with no photo or phonophobia, no aura, no autonomic symptoms, nothing like that. At acute stage, you can give analgesics and NSAIDs and acetaminophen. All can stop it. TCAs can be utilized like amitriptyline, which is tricyclic antidepressant, and behavioral therapy will make it go away. So, they say here, compare with the trigeminal neuralgia, which produces repetitive unilateral shooting or shock-like pain with distribution of cranial nerve number 5. Basically, they are trying to tell us that do not mistaking the headache, for example, the cluster headache, with the trigeminal neuralgia, because in the cluster headache it's only the eye, while trigeminal headache is all of the face. Okay? So, triggered by showing, talking, touching certain areas of the face, and it can last seconds to minutes. But episodes often increase in intensity and the frequency over time. The first line therapy in that case is carbamazepine, okay? In trigeminal neuralgia, I mean, not cluster headache. Cluster headache is sumatriptan and O2. Don't forget about the O2. Now, this is just general terminology of movement disorder. The first thing is akathisia, which is, you know, you tell the patient to sit, he cannot sit, he has to keep moving. So, restlessness and intensive urge to move, it can be seen with neuroleptics use or a side effect of Parkinson treatment. Basically, it can be, with neuroleptic use most often, because when you use a neuroleptic, what you are doing basically is reducing the amount of dopamine in the body, and that will lead to extrapyramidal symptoms. The extrapyramidal symptoms include akathisia, which is restlessness, because it affects the basal ganglia. Asterixis is an extension of the rest, causing a flapping motion. If you remember, we spoke about this asterixis before in hepatic encephalopathy, associated with hepatic encephalopathy, Wilson disease as well, and other metabolic derangement. Athetosis is a slow snake-like writhing movement. If you attended not the previous class, but the class before it, we spoke about these, especially seen in the fingers, a snake-like movement. It's a basal ganglia dysfunction, especially in the caudate and the putamen, which is known as the striatum. The same with chorea, actually, seen in Huntington disease. Chorea, a sudden, jerky, purposeless movement, which is due to basal ganglia. It can be seen with Huntington disease, as you can see, and acute rheumatic fever. That case is symptom chorea. However, in the Huntington, it's irreversible and the patient is going to die. In acute rheumatic fever, it's totally reversible. Dystonia, a sustained involuntary muscle contraction. It can be a side effect of, for example, neuroleptic medication. We have the rotary cramp that occurs in the fingers as well, and the blepharospasm, and torticollis, which is a constant contraction of the sternocleidomastoideus, preventing you from the ability to move your neck. Treatment is with botulinum toxin injection to relax the muscle contraction. Essential tremor versus intention tremor. It's super important to differentiate between these. Personally, I used to mix them up together. This is wrong. Starting with the essential tremor. This disease is familial, meaning that if your father have it, you will have it. It's a high-frequency tremor with a sustained posture and outstretched arms. So it's worsened with movement or when anxious. Basically, if you become anxious, it's going to become worse. You will start shaking more. And when you tell the patient, for example, can you take this Benset and grab something and put it inside of the tube, that will be horrible for him to do, okay? So that's essential tremor. Often familial, patients often self-medicate themselves with alcohol because alcohol actually do stop the tremor, which decreases the tremor amplitude. The treatment is non-selective beta blocker like propranolol and barabutyrate like brimidone. Brimidone is an an anti-epileptic medication that actually do work on essential tremor. It's a second-line therapy because some people don't, basically it's contraindicated to get the propranolol, like people with asthma or people who have bradycardia as well. Intentional tremor is a slow, zigzag motion when pointing, extending towards the target. So the patient, you will give him your finger and be like, can you touch my finger? And he's like, ah. It's difficult for him to get it. Why? Because the cerebellar dysfunction make a poor proprioception and knowing where is the patient joint located in the space. Resting tremor is an uncontrolled movement of the distal appendages, most noticeable in the fingers. A tremor is alleviated by intentional movement. So as long as the patient is resting, he's shaking. The moment he wanna grab something, no tremor, it goes away. This is highly, highly important. This is a sign of Parkinson's disease. Basically, it's the opposite of essential tremor, which is when you are doing nothing, essential tremor don't exist. But if you purposefully try to do something, the tremor gets worse. The resting tremor is vice versa, which means if you do nothing, you are shaking. If you start to do something, it goes away. It's a lesion into the substantia nigra in Parkinson's disease. It occurs at rest. It's a bell rolling tremor. Basically, the patient keeps shaking on rest of Parkinson's disease. Hemipalismus, if you remember, we spoke about this the other day. It's a subthalamic nucleus, basically hemorrhagic infarction, due to a lacunar stroke that happens as a complication of microaneurysm. You remember the Charcot-Bouchard aneurysm that led by hypertension. That happens because of hypertension, chronic hypertension. Okay, the next thing is myoclonus. It's a sudden, brief, uncontrolled muscle contraction, which happens mostly before sleep and mostly due to metabolic abnormalities, but they can be due to something else. So they write, jerks and hiccup, common metabolic abnormalities like renal and liver disease, also can be due to a prion disease, if you remember, Creutzfeldt-Jakob disease. It was a prion disease. So finally, restless leg syndrome, quite common, an uncomfortable sensation in the leg, causing an irresistible urge to move them, relieved by movement, and it's worse at night. And the most common person to complain from them is the wife of the person. And it's associated with iron deficiency and chronic kidney disease. The treatment is with a dopamine agonist and the bramipaxol and robinarole. Okay, so these are the treatment agent. Good. So the next thing we'll speak about is neurodegenerative disorder. Let me just take a quick look. Okay, so hopefully tomorrow we'll finish the pathology of it, but let's push a couple of more pushes today. So we have neurodegenerative diseases. We have quite a few of them, as you can see, so many of them actually. So neurodegenerative disease, we have Parkinson's disease, Huntington disease, Alzheimer's disease, frontotemporal disease, Lewy body dementia, vascular dementia, Creutzfeldt-Jakob disease, HIV-associated dementia. That's a lot, yes. The problematic thing about them, it's not how to know why the symptoms, how it's occurring and all of that. No. The problematic thing about neurodegenerative disease is that you need to differentiate them between each other, okay? So, decrease in the cognitive ability, memory, and function with intact consciousness. This patient will be conscious, but they will have some problems. And it's progressive. All of these are progressive, guys. Progressive means that it gets worse. You must rule out depression as a cause of dementia, because people who are really depressed start to develop dementia. We call that pseudodementia. Other reversible causes should also be ruled out. Always, before you think about anything else that can lead to neurodegenerative and dementia symptoms, you need to rule out the other causes. Metabolic causes such as hypothyroidism and vitamin 12 deficiency, neurosyphilis, and normal Brescia hydrocephalus. All of these are reversible, guys. That's why you need to rule them out first. Parkinson's disease. So Parkinson, it traps your body. So the patient will have a tremor, a bell-rolling tremor at rest, rigidity, a cogwheel rigidity. Oh, so what is this cogwheel rigidity? The cogwheel rigidity, if this is the limb of the patient and you are trying to push it down, okay? You, instead of it's moving like, whoa, it will be like, it will be really difficult to pull it with you. So we call that cogwheel rigidity. Let's take a look at a cogwheel rigidity.
This is due to rigidity of the
See, basically it's pretty difficult to move their hand down or up, the same problem. Okay, good. So that's Coguir rigidity, akinesia or bradykinesia, which is decreased in movement, postural instability. So this patient cannot stay in normal, like standing with my back up. Shuffling gait. I like shuffling gait. So they also like to call it like magnetic gait. So this patient will be stuck to the ground, kinda. So look at this guy. So they don't rise their legs a lot from the ground. See? Oh, wait, no. Yeah, he likes to stay to the ground, but I really don't like this one. Shuffling gait, they like to... Okay, so this is a lady with Parkinson. Okay, seriously? See, she's kind of stuck to the ground. Magnetic gait, stuck to the ground. Okay, so the next thing is small hand writing. We call it micrographia. So you tell them write your name. So instead of writing like this, they write something like this. Okay. So dementia is usually a late finding. So there is a narcotic, a drug called MBTB. It's contaminated in illegal drugs, and it basically, this MBTB is going to convert to MBB inside of your body, and that will destroy your substantia nigra. So if you get a young patient with Parkinson's disease, start thinking about MBTB due to an illicit drugs. Okay. By the way, if you destroy the substantia nigra, will it regrow and everything will be fine when you stop the drug? Or you got this problem for life? Well, reality, irreversible, exactly. The patient is screwed. Histologically, you will see a loss of the dopaminergic neurons in the substantia nigra pars compacta. And the patient is also going to develop Lewy body. What is Lewy body? I will show you in a second. But basically, they are an intracellular... Okay, here is a Lewy body, this thing. It's an intracellular inside of the neurons, basically, a composition of alpha-synuclein. So this is just, you must actually memorize that. It's an intracellular eosinophilic inclusion made out of alpha-synuclein. So that is a Lewy body. Please be careful, because Lewy body can be seen in Parkinson's disease and also in Lewy body dementia. However, the symptoms are different from each other. So that's how you differentiate between them. Otherwise, there is no other way to differentiate the symptoms. So the next disease I'm going to speak about is Lewy body dementia. Lewy body dementia, the patient will be able to see Lewy. That's how I imagine it. Basically, the patient will have visual hallucination and dementia with a fluctuating consciousness, but they will have actual visual hallucination, which is rare. So dementia with a fluctuating cognition and alertness, REM sleep behavior disorder. Well, basically, this poor patient will be waking up from their sleep during the night with multiple nightmares, not night terrors, nightmares, because REM sleep. And Parkinsonism, the shaking symptoms, you are like, shit, well, this sounds exactly like Parkinson's disease. They have Lewy body like Parkinson's disease. So how the hell I'm going to differentiate between them? The first trick to differentiate between the two is time. It's all about time. Called Lewy body dementia if cognitive and motor symptoms onset are less than a year apart. So otherwise, it's considered dementia secondary to the Parkinson disease. What I mean by that, if we put the time here, this is the start of the symptoms, okay? Symptoms start here. Here, it's 12 months, 1 year. If you do have the cognitive and the motor problem here, you do have Lewy body dementia. If you do have the cognitive problem here, if you do have here the motor problem only, and here you start developing the cognitive problem, this is Parkinson disease complicated by dementia. Let me repeat what I just said. This is the initiation of the disease. This is 12 months. And this is actually, let me just make it here. So this is 12 months. This is the beginning. If you do have both motor, cognitive, and motor symptoms together occurring, this is Lewy body dementia. End of the story, not difficult. If you have the cognitive disorder, and then, if you do have the motor disorder, which is the Parkinsonism, and then you develop the cognitive disorder 12 months later, this is just Parkinson disease complicated by dementia. Okay? That's the way to differentiate between Lewy body dementia and the other one, Parkinsonism. In Lewy body dementia, the Lewy body is in the cortex, while in case of Parkinson disease, they are in the substantia nigra pars compacta. The next disease to speak about is Huntington disease, which is an autosomal dominant trinucleotide repeat expansion in the Huntington gene. It's 4 letters, the hunt, so yeah, that's chromosome 4. Remember, when you hunt something, you put it inside of a cage, right? So that's the CAG repeat. So symptoms manifest between age 20 and 50. Chorea, athetosis, aggression, depression, dementia can occur in the patient. Sometimes initially mistaken for substance use, but the patient has a family history. This poor patient will have this motor dysfunction, they will become really depressed, and they can hurt some family members. For some reason, it's autosomal dominant, but for some reason, they are mostly men, okay? Anticipation results from expansion of the cage repeat, and the caudate will be losing acetylcholine and GABA, so the CAG conveniently. Remember that it leads to a destruction of something known as the striatum, which is composed from 2 structures actually. The striatum is composed from the caudate and the putamen. So you will have atrophy of the caudate and the putamen, which will lead to something called ex-vacuo-ventriculomegaly. What is ex-vacuo-ventriculomegaly? Ex-vacuo-ventriculomegaly is due to the absence of a structure, due to the decrease of the brain tissue, you will have your ventriculi enlarged. Remember the law I told you about before. I told you inside of your skull, you have a brain tissue, you have CSF, and you have a blood. Blood, CSF, and tissue. If you have less tissue, you will get more CSF. That is the cause of ex-vacuo-ventriculomegaly. Due to the absence of putamen and caudate, you will get bigger ventricles. The patient will have more dopamine, less GABA, less acetylcholine in the brain. Neuronal death occurs because of the NMDR receptor binding and the glutamate excitotoxicity. So the glutamate can lead to an actual destruction of the tissue in that this excitotoxicity occurs basically because the neuronal cells, let's say that this is a neuronal cells, there is something called the NAMDA receptor, and the patient with Huntington will have a lot of glutamate that will lead to activation of that death receptor that destroy the neurons. The next cause of dementia is Alzheimer's disease, and in case of Alzheimer's disease, it goes something like this. Alzheimer's disease is the most common cause of dementia in the elderly population, and it goes as follows. It's a progressive type of dementia. Remember, when we speak about cognition, if the cognition was here and it suddenly fall down, we call that delirium. But if the cognition was here and slowly it fell down, we call that dementia. Alzheimer's disease is more common in people with Down syndrome. The reason being that in Down syndrome, you have 3 copies of chromosome 21 instead of 2. Normal people have 2 copies of chromosome 21. Alzheimer's disease patient have 3. This is also encoded chromosome 21 for the amyloid gene, okay? So instead of having 2 genes, you will have 3 genes. So you will have more amyloidosis of the brain, which lead to the Alzheimer's disease. Down syndrome patient have increased risk of developing early onset Alzheimer's disease as the ABB, which is the amyloid precursor protein, is located at the chromosome 21. These patients will be suffering from decreased acetylcholine, which exacerbate the dementia. So acetylcholine analogs can improve the symptoms of the patient. In general, people with Alzheimer's disease live around 10 years after the diagnosis, 10 to 15. The progressivity of the symptoms will be as follows. If this is year 1 and this is year 10, which is the death, the progressivity of the symptoms is something like this. So they will be completely functionless in a few years. Actually, it's something like this, I'm sorry. So they will lose all of their function until their death. However, with the proper treatment, with the drugs that increase the acetylcholine, instead of it being like this, you can make it like this. So still, the patient will die. The patient will have, at the same time, basically, it does not improve the mortality. However, he will die with retaining some of his functional memories meanwhile, which is good. Associated with the following altered protein, there is something known as ApoE2 and ApoE4. Basically, this is a genetic testing type of thing. If the ApoE2 is the one present, that decreases the form of the sporadic form of Alzheimer, which means if my father has Alzheimer and I want to check if I'm at risk of Alzheimer, I can check these. If I do have the ApoE4, I have high risk of the sporadic form at early age. But if I have the ApoE2, I have less risk. It's easy. Follow the numbers. E, less risk. 4, high risk. So this thing, amyloid precursor protein, preselin 1 and 2, and familial forms have early onset if they are mutated and they are present. Widespread cortical atrophy in normal cortex. Yeah, so they have a picture here, normal cortex in Alzheimer's disease. Let's take a look. Oh, okay, so this is normal. This is Alzheimer's disease patient. So you can see here, this is normal. You have all of the brain tissue. Here you can notice that the ventriculi are much bigger, right? Here you can see wide empty spaces. All of that because the atrophy of the brain lead to the ventricles to become bigger, which we, as we said, we call it extraventriculomegaly, especially in the hippocampus, as you saw in that picture. So the hippocampus, if you take a look at this is basically the lateral sulcus. This is the medial fissure of the brain. So the lateral sulcus, under it is the temporal lobe, and this is, we call it the hippocampus is here. Hippocampus is responsible for the creation of new memories. So yeah, that will be gone. Where it is? Yes, it's gone. Narrowing of the gyri and widening of the sulci is all symptoms of atrophy of the brain. Senile plaque, which is a histological finding, can be seen on the gray matter. So let's take a look. So these are the plaques, as you can see here and here. This is the senile plaque. These patients also may cause amyloid angiopathy and intracranial hemorrhage. What's up with that? Well, these patients, the amyloid angiopathy, I want you to understand the idea. It's most commonly to be subdural hematoma. Why? Because the brain is becoming atrophied, right? If this is the dura mater, this is the arachnoid mater. Between them, you have something called the bridging vein. Bridging vein. Here you do have your brain, your actual brain. If the brain will become smaller, let's make it smaller. Why? Because of the atrophy in Alzheimer's disease. The arachnoid is near the brain, it's stuck to the brain. So what is going to happen to the bridging vein, guys? What do you think? What will happen to the bridging vein? Instead of them being relaxed like this, they become stretched. So what do you think? Variant 1 or variant 2 have a higher risk of destruction and rupture? Logically, it's variant 2. That's why people have this amyloid angiopathy. I hope you understand. Intracranial hemorrhage can happen. So AB amyloid B is synthesized by cleaving of the amyloid precursor protein, which is increased in case of Down syndrome, right? Neurofibrillatory tangles can be seen as well, which is basically intracellular tangles that are made out of tau protein. If you see this structure, this is not the tangles. The tangles is the thing inside of it. I'm going to draw it here, and then I'm going to remove it. I hope you see it. I hope you see it. This is fibrillary tangles. So this fibrillary tangle, neurofibrillary tangles, it's not the only disease we see it in. There is another disease, but for now, just think Alzheimer. So yeah, it's an intracellular hyperphosphorylated tau protein. They do ask about the tau protein. Insoluble cytoskeletal element, numbers of the tangle correlates with how bad is the dementia. Logically, a brain biopsy is not done commonly. So most likely we will see this post-mortem. Hirano bodies are an intracellular eosinophilic proteins rod in the hippocampus. They almost never ask about this, but for the sake of completeness, I will show it to you. Hirano bodies in the hippo. Oh, okay. Okay. This guy. This is Hirano body. Generally, they never ask about it, guys. So, that's Alzheimer's disease. Remember, tau protein in the neurofibrillary tangles is hyperphosphorylated. Also, don't forget about the senile plaques that can be seen in the brain. Remember that its association with Down syndrome, right? Because they have more chromosomes, 21 chromosomes, which contain the amyloid precursor protein, meaning more amyloid. The next disease I'm going to speak about it is frontal temporal dementia. I want you to think frontal is before temporal. Frontal lobe is responsible for the behavior, temporal lobe is responsible for the memory. So the patient behavioral symptoms will be before the memory symptoms. So formerly known as big disease, early changes in the personality and the behavior. Why? Because the frontal is before temporal. Behavioral variant and aphasia, primary progressive aphasia. So they cannot speak after sometimes. May have associated movement disorder. Frontotemporal lobe degeneration, so mainly the frontal lobe and the temporal lobe will be messed up. This is the temporal lobe in this case, as you can see it's gone basically. The ventricles are huge because of ex vaccio ventriculomegaly, which means absence of the brain tissue will lead the ventricles to become bigger in size. Okay, so frontotemporal dementia, inclusion of hyperphosphorylated tau protein again, but in this time they will be round. They will not be as before. So if you see hyperphosphorylated tau protein and they show you a round structure, think Beck disease, which is frontotemporal dementia. But if they mention it to you and show you this picture inside like neurofibrillary tangles, think Alzheimer's disease. Okay, good. Lewy body, we mentioned it. Now vascular dementia. Vascular dementia is a stepwise decline in the memory. What do I mean by that? Let's say that the patient cognition is right here. In case of Alzheimer, it's going down like this. In case of vascular dementia, it's going to go down like boom, 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 boom. So what is happening? Stroke, minor stroke, another minor stroke, another minor stroke, complete dementia. Vascular dementia result as a multiple arterial infarction or chronic ischemia of the brain. Stepwise decline in the cognitive ability with a late onset of memory impairment, second most common cause of dementia in old people. MRI or CT scan will show multiple cortical and subcortical infarction. Creutzfeldt-Jacobs disease, we spoke about it before in microbiology, that was present due to prions infection. Prions are an improperly folded proteins in the brain, okay? And the idea is like this. The patient with the Creutzfeldt-Jakob disease have a rapidly progressive disease in which like within less than a year, the patient will be dead, okay? So rapidly progressive dementia with myoclonus, which is a type of an improper movement that I showed you before. They have this like I want to fly type of movement, like rapid movement of the hand, and ataxia. It's associated with a periodic sharp wave on the EEG. This, you should know how they write it. You should not know any EEG in the USMLE. You should know the words. I mean, the 3 hertz spike and wave. That's absent seizure. You don't have to know how it looks like on the EEG, but you need to know what is the wording of it. And an increase of this marker, 14-3-3 protein in the CSF. It may be transmitted with contaminated material like corneal transplant and neurosurgical equipment. It's quite fatal. It could kill the patient within a year. People will be like, but wait a second, how neurosurgical equipment can transmit Creutzfeldt-Jakob disease and we autoclave them? We clean them. Well, the autoclave will not work against the prions. They can survive it. It's a spongiform cortex will be apparent. They love to show you a picture of histology of that. I'm not sure if it exists. Okay, they do put it here. So it looks like a sponge, basically. If you see here, this is like a piece of a sponge, SpongeBob, and you can see multiple emptiness inside of it. That's a spongiform type of cortex. The prions is going to convert the prion C into SC. The SC is the pathological one. It's a type of a protein located in our brain. Beta-plated sheets resistant to proteases. It doesn't matter which substance you will give, it cannot end this. The patient is going to die. This is just a fact. It's a matter of when, mostly 6 to 12 months. He's going to die. The idea here that when he is dead and you want to perform an autopsy, you need to be really careful yourself for your own life, not for his. He's dead. Also, he is not allowed for a transplantation of his cornea. Okay? Just keep that in mind. HIV-associated dementia. Guys, if somebody asks you, what is the in which cell inside of the brain is HIV infecting? Which cell of the brain HIV infects? Which cell of the brain HIV infects? Yes, excellent, good. So basically it's going to be the macrophage of the brain. HIV infect 2 cells, the CD4 and the macrophage. In the brain, we have the macrophage, the microglial cells, also known as the microbial cell. So that will be the one infected in the brain. Subcortical dysfunction associated with advanced HIV infection. It's directly from the HIV. Why I'm so specific about that? Because most problems that occur in HIV are not from the HIV. They are just because of absence of immunity. But this one is directly because of the HIV. It's characterized by a cognitive deficits, gait disturbance, irritability, and a depressed mood. Diffuse gray matter and the gray subcortical atrophy that also lead to exvacioventriculomegaly, which is due to the decrease of the tissue of the brain. The ventriculi gets bigger. Microglial nodules with a multinucleated giant cells. What is the giant cells? Giant cells is plenty of macrophages in the same place. So basically one big cells with multiple big nuclei inside of it. This is a giant cells and it's composed from microglial cells and they are infected with HIV. Good. So let me just take a quick look because I'm planning on finishing this tomorrow. So I want to just see how much we can finish in one day. 1, 2, 3, 4, 5, and 6, 7. No, that might take one more day. Okay, guys. So that's it for today's session, and I will see you guys tomorrow.